Thank you for staying. It's not easy to give this talk after such nice lectures. I will be presenting some of our data, and perhaps it's something at I would say lower level or more practical level than those beautiful talks that were given before. I would like to disclose you my conflicts of interest, and part of our research is supported by some companies active in electrical impedance tomography. So I think it's important whenever we have a new technique not to run into the risk of looking for a question so that we can use our new device to answer this question, right? I think the starting point should always be a clinical problem and looking for what is the best solution to approach the clinical problem. So do we have a problem in setting the PEEP? I would say yes, it's still an argument which is debated. It's still something we need to dive more into. Why is this? These are the data from the LungSafe studies we published last year, and the levels of PEEP that are applied in the current clinical practice in our units are still, I would say, rather low as compared to what is reported in the literature. For example, if you look at the red bar, it's 10 of PEEP, and you can see that exactly 50% of the patients who are on pure oxygen on day one are on a PEEP level of 10 or less. And then you can say, well, but this is day one, patient had just entered the ICU, give us a break. So this is day two, but what you see is that on day two, yes, patients are doing better. We finally can drop FiO2 from 100% to 70% in severe ARDS, but the level of PEEP are exactly the same. These are unpublished data, and so it's unpublished the result that if you look at the PEEP settings on day two in the vast majority of patients, these were exactly the same as of day 5 in most cases. So I think we keep discussing at our meetings on what's the best way to set PEEP, but it looks like sometimes we really do not even try to adjust PEEP. So perhaps one of the reasons clinicians are still a bit reluctant to spend time adjusting PEEP is the lack of something that is clinically available, and it's really a bedside guide for this clinical relevant problem, I would say. And I think that in these years, the possibility of using electrical impedance tomography has emerged, and it's gaining more and more prominence in the literature. So I will not dive much into the details of electrical impedance tomography, into the technical details, but as perhaps many of you know, there is a belt surrounding the patient, and a small electrode, a small current is injected through the electrodes. It rotates very quickly, so even though the machine has a relatively low spatial resolution, the temporal resolution is very good. So at the first stage, the, I would say, lowest hanging fruit we can have with EIT, and it's also the more robust information that EIT can provide, is the regional distribution of ventilation. This is the regional distribution of tidal volume. As you see here, when the PEEP was set according to ARDS network strategy, tidal volume was predominantly ventilating the ventral part of the lungs with 42 and 30% of the ventilation. So again, 72%, the magic number for PEEP. Yeah, that was a joke. Ventilating the ventral parts. And so when investigators and Dr. Cinella from Italy has applied to these patients an open lung approach, as you can see now, the distribution of ventilation, our little ghost here becomes more homogeneous, and indeed we have about a much more even distribution of ventilation across the different layers of the lungs. So yes, EIT can image the distribution of ventilation, and especially the changes of the regional ventilation induced by PEEP setting. There is another parameter which we can get by EIT. So this is, I go back one slide, this is ventilation, so dynamic changes of aeration. The other number we can get is the change in end expiratory lung volume. So EIT has a hard time with absolute numbers. You really cannot quantify by EIT by itself the end expiratory lung volume, but whenever this end expiratory lung volume changes, EIT is able to detect it. So in this study done by Tommaso Mauri at the time in Monza, he has demonstrated the effects of periodic SIGs, so large inflation of the lung. You see here temporary increase of the airway pressure to 35 centimeters of water, and indeed, as you see, the end expiratory lung volume does not go back to baseline. After 1 or 2 SIG, we have a persisting volume of air in the lung, which in this case is interpreted as recruitment, as PEEP did not change. And this is another study by the group of Ines Frerichs, and it's really, her group has taught us many of the things we know about EIT, where they have studied the effect of PEEP changes on the heterogeneity of the lung ventilation, as measured again by EIT in animals, and they have shown that as soon as PEEP was increased, it was possible to find a level at which heterogeneity was minimal, and at which, so perhaps, I think without perhaps, ventilation was more evenly distributed. Now, clearly this was also associated to the point of best compliance. And of course, this is a very important study that shows that indeed EIT can be used to titrate PEEP, although as in many of these animal preliminary studies, you see that there are huge changes in PEEP, of course, to see the signal. But I guess at the bedside, we are not like asking ourselves, should this patient have 2 or 18 of PEEP, right? We are more debating between 10 and 12 or 8 and 14, something like that. So the idea is, can we use EIT at the bedside to titrate PEEP? This was our simple goal, to assess whether we could guide PEEP setting by EIT. Now, there is a little catch with EIT and also, for example, with end expiratory lung volume, is the fact that as opposed to, for example, a SIG that then goes back to the same PEEP level, and so if you see in that condition an increase in end expiratory lung volume, that is almost certainly recruitment. When you change PEEP, you see this is time, tidal ventilation, and end expiratory lung volume. Whenever you change PEEP, end expiratory lung volume will increase. In every subject, in everybody of us, end expiratory lung volume will increase. And this is the sum of 2 components. One is alveolar distension. Normal alveoli are put at a higher pressure, and so they expand. And alveolar recruitment, and this is what we are looking for. We like PEEP when it induces alveolar, or when it stabilizes alveolar recruitment, not just when it distends already opened lung unit. I skipped through this quickly because I want to spend a little bit more time on this part. So again, going back to our question, can we then use still EIT to titrate PEEP at the bedside? So we took advantage of something that is very well known in pathophysiology of ARDS, and this is the fact that, yes, recruitment is an inspiratory phenomenon. So these are the frequency of the opening pressure of the alveoli. You see some alveoli need 10 centimeters of water to open, some of them require 20, some of them require up to 30, and blah, blah, blah. However, in red here, you have the closing pressure. And most alveoli stay open until the pressure does not drop below, for example, in this case, 10. So we reasoned, perhaps we can apply this principle and monitor these phenomena by means of EIT. And this is an idea that a colleague of us, Nilde Ronia, working in our institution, had, and we designed a protocol based on this idea. So this is our tidal ventilation. We give a 40 by 40 recruitment maneuver. You can use other recruitment maneuvers. Of course, when the article was under peer review, somebody asked, why did you use that maneuver? And my short answer was, why not? But anyway, any recruitment maneuver would work. And it does work, because you see, this is the same PEEP level, and the expiratory lung volume does increase. And to me, this means that we recruited some lung. But as soon as the time goes by, you see that this is lost. So this means that we went up here, but then with our PEEP, we were still somewhere here, and so there was a whole bunch of alveoli that was closing. And so we give another recruitment maneuver, increase PEEP by 2 centimeters of water, and at this point, we obtain a stable recruitment. So we said, okay, let's test if in a group of patients with ARDS, we can use this technique to, this approach to set PEEP. And this is what we did. Our primary endpoint was, again, a lower hanging fruit, just because I'm lazy, so we went for feasibility, that you can do whatever you want and it will work. And secondary endpoints, no, I'm joking, but really this was something we wanted to test. Is it feasible or not? And then we went for secondary endpoints such as PEEP level in itself, oxygenation, and EIT-derived data. So we started from, we don't use this in our clinical practice, but it's always, I would say, a good starting point to use the NIH table. So we set PEEP according to FiO2 and oxygenation to get on the, to land on the NIH table. And then we went on, we started our EIT monitoring, gave a recruitment maneuver, and another one, and the figure should show up, yes. And we went on until we were happy to see that the drop following the recruitment maneuver was above 10%. 10% is an arbitrary threshold, I agree, but this was what we decided to use from a pragmatical standpoint. So in this case, you see end expiratory lung volume drops, so PEEP is not enough. So we went on until we would see that, yes, recruitment is stable, as I've shown you before. And of course, we put, as this was a feasibility and safety study, we put a safety threshold at 18 centimeters of water, just to avoid that we would end up with 50 of PEEP and blow the patient up. And we also added an extra step, 2 centimeters of water above. So what are our findings? This is just to summarize the protocol, as you've seen already. We studied 16 patients, mostly of them had ARDS, and all of them had hypoxemic respiratory failure. This approach was feasible in 14 out of 16 patients, and in 2 patients we simply could not get, for as much as we've tried, a signal of EIT that was stable enough to follow our protocol. You see here, and the expiratory lung volume jumps up and then comes down again, and then, I mean, the signal was just not reliable. But this was not the case in the vast majority of patients. The PEEP we ended up setting was slightly higher than what is described by the ARDS network table, 4 centimeters of water. So again, suggesting that by EIT, we will be able to obtain fine-tunings of the PEEP at the bedside with a mean number of changes required of 2 steps. In our population, and I'm finished, the amount of recruitment was not directly associated with the amount of with the improvement in oxygenation, which was there. There was an increase in oxygenation, but no correlation with recruitment. There was a significant association with the change in compliance, but the change in compliance were quite small. Within 5, 6 ml per centimeter of water. So you really need to have a super precise measurement of compliance, whereas the signal of the amount of recruited volume was very large. So I go to my conclusions as time is finished. We think that tools to individualize PEEP at the bedside are needed, and that these tools should take into account lung heterogeneity. We feel like EIT is a promising tool, particularly because it not only allows to monitor recruitment, but also to detect overdistension. But clearly we have to show that this is something we don't do because we like to show a physiologic principle in place, but because we are affecting by any means the patient's outcome. Thank you very much for your attention.
Thanks a lot for this very interesting talk. Are there questions from the room? Yeah, there is one over there.
I already know that your question will be too difficult.
João Batista Borges. Thank you, Bellani. Thank you for a very nice presentation. Thank you for work on this area that we need more partners. And do you agree that, because you did all the time in this protocol in particular, you did 40 seconds, 40 centimeters of water, 40 seconds, right?
Yes.
And then if you have this drop in the inspiratory lung volume, you hear repeated. Do you agree that I think that what you measure was, what was the PEEP that can stabilize what you recruited with 40?
Yes.
So you have no idea of other areas,
Yes.
more than 40 to open? And
Yes, I agree. The reason why we choose 40 by 40, and of course I know that the work by you guys shows that there is something more which can be recruited. The reason why we chose 40 by 40 was quite pragmatical. It meant to be really a feasibility study. It's what we do in our clinical practice, and we knew that it's what we do, what is accepted in our ICU, and that's what we use. But I agree that if we aimed for a full lung recruitment, perhaps we should have used a higher pressure.
I have nothing against, I think it's a very perfect protocol for feasibility. It's only that the message should be clear that
Yes.
It's not necessary that you change the protocol, but it's only some population that
Yes.
opens with 40 that you titrated the PEEP. Yeah.
Yes. Thank you.
We have time for a last question.
Thank you for a nice presentation.
Thank you.
I have one question. What kind of strategy did you use? A pressure control mode or volume control mode, constant pressure?
For tidal ventilation,
Yeah.
we use volume control. We use the
control.
volume control square flow. This is also part of our clinical practice. As we were changing the PEEP, we prefer not to change also tidal volume, so we didn't use pressure control. And just to tell you, as compliance went up, of course, driving pressure went slightly down, but like 1 centimeter of water, something like that. Because clearly, the vast majority of the signal you get in terms of compliance, you get it from the alveoli that are open already.
But what you saw is that there was a higher PEEP, but the increase in compliance didn't increase that much. Couldn't that be explained by the higher PEEP and then also part of overdistension, where there is a decrease in compliance in the ventral
Yeah,
pulse?
sorry, I had to go a bit quickly. Of course, we had seen some overdistension. If you look, this is the regional compliance, and the ventral region are showing some overdistension as regional compliance is going down. So I think that an interesting point of EIT is exactly that one, that out of one number of compliance that takes into account, that is affected mostly by the lung which is already open, and then has some effects of recruitment and overdistension, you can dissect those parts out. And clearly, I mean, EIT by itself will not prevent overdistension at all. The point is that now we can know how much we are overdistending the lung. And what is the price to pay? It's something we have to think about carefully. But the point is, we can now see what we are doing.
Yeah, that's the same one that I see, and then what I do is decrease delta pressure or decrease tidal volume afterwards.
Exactly.
It's possible.
Exactly. It's possible. It's possible until you reach again, and I'll be silent, the same compliance that you had at RDS network PEEP. So yes, it's totally doable. Thank you so much for this comment. Thank you.
Thanks a lot.
Thanks, Liz.
Thank you, Giacomo.